Hi, I'm Frank Diamond, the Managing Editor of Infection Control Today. We're giving infection preventionists and other healthcare professionals the information they need to battle COVID-19. Joining me today is Jason Tetro. You may know him. Jason is the host of the podcast, Super Awesome Science Show. And he's also written two well-regarded books, The Germ Code and The Germ Files. He's worked in various fields, including environmental microbiology, disinfection, and antisepsis, and can talk about emerging pathogens. Jason, thanks for joining us today.
Oh, it's great to be with you.
Let's dive right in. How do you think COVID-19 will change the working lives of our readers and viewers who are infection preventionists at healthcare institutions for the most part, and also not just infection preventionists, but hospital administrators, environmental service crews, procurement teams, sterile disinfecting teams. COVID has changed so much in our lives already, even after the vaccine is found, and even after COVID goes away. You think some of those changes are going to be permanent?
There's going to be one big change, and it's something that many of us have been asking for a very long time. It's going to be the addition of a word. You see, back in the good old days before the 1970s, we had infection control. And then sort of as we got into the 1980s and we started realizing, blood can be very problematic, especially when things like HIV and that, we eventually became infection prevention and control. And we started getting into precautions and how we can sort of react to the presence of some kind of entity that causes us a concern. And so we developed all sorts of types of testing so that we could essentially find out very, very quickly whether or not a patient could possibly lead to spread. But now in the age of COVID, we have what is known as preparedness. Now this came about back in around SARS. We actually started seeing infection prevention, control, and preparedness coming out, but it never took off. And right now, it is more about preparedness than it is about prevention and control. And I think we are finally in the stage now where we can go ahead of the curve as opposed to trying to deal with it or somehow find a way to control it after it's already spread. So essentially, think of an infection like COVID-19, SARS-CoV-2, as a brush fire, a wildfire. Imagine if we could figure out where it was going to hit in advance so that we could knock it down before it even starts. That's the preparedness factor. And I think we're finally at a stage where we're going to be incorporating that, and it's going to stick around.
So what's the difference between prevention and preparedness? It seems like you're close to being the same thing, but I guess preparedness is more you're thinking in regional terms, or and I guess prevention is more within the hospital itself. Is that?
Yeah. So when you're talking about prevention, you really are talking about your establishment, your institution. And that's very, very important because essentially for healthcare quality, you have to make sure that your institution is satisfying your patients, basically. Now, the problem is that if something happens to come into your environment and you're not prepared for it, then what happens is that that protection becomes a bit more problematic. And then all of a sudden, your preventative measures are coming in, perhaps maybe a tick too late, but in many cases, it's several days too late. All of a sudden, something has shown up. You don't know what to do, and you've got to figure out how to not only develop the control, but then work backwards to prevention. When you have preparedness, that is essentially saying is you're looking at your region and beyond that, and you're working in a multidisciplinary environment where you have numerous stakeholders who are providing information. It could be the media, it could be politicians, it could be epidemiologists. They're all working together to provide that preparedness that eventually gives you in your institution the ability to know what may or may not be coming. But more importantly, when we do see something, as we saw with SARS-CoV-2, you can actually start getting yourself ready. And the funny thing is that those places where there has been preparedness already sort of in the program, they've actually done incredibly well, not only as what they call flattening the curve, but also making sure that there's very few to almost no healthcare associated infections in their institutions. Now, again, I'm talking more along the lines of hospitals, but I'm hoping that as we're moving forward, based on what we've seen with long-term care facilities, that we can also start incorporating preparedness for them as well.
Preparedness embedded in their systems. Now, what does that look like, and where do you find it?
So what would end up happening is that you have a regional unit, and that region, whether it be run by the local municipality, whether it be something that has been assigned by a larger governmental authority, you have a group of people who are essentially working to find out what is going on outside of your region on a regular basis, and then reporting back to the region about what is happening. Now, here in Canada, we actually had something along the lines called the Global Public Health Intelligence Network, pardon me. And when that came into play, you started seeing the ability of tracking all sorts of other types of places around Canada without actually worrying about what's happening inside of Canada. Another good sort of early warning system, which could be part of preparedness, is what is known as the ProMed Mail. And what this does is it looks at all the reports that are coming out of anywhere in the world of something that seems infectious, pathogenic, whatever it may be. So when you start incorporating that in a framework that actually is part of your process, whether it be once a month, once a season, whatever it may be, you then get a sense of what's coming. And then if you have it in place so that you essentially have breaking news, if you will, then authorities can then notify hospitals and other institutions that there is this threat and that they should start putting in their preventative measures to make sure that if it does arrive at their doorstep, they are ready for it.
Isn't this something that the World Health Organization should be doing?
The World Health Organization has a mandate to be able to try and help any kind of healthcare institution, government, whatever it may be, in being prepared, yes. The problem is that they're usually second on the list. So normally what ends up happening is that information comes out and it goes to the regional authority, especially if it's notifiable. If it's a non-notifiable and it's unknown, sometimes it just circulates within the institution where everyone's like, I don't know what this is. Yeah. And then it goes. And then from there, it may go to a national institution. And then it may go to the World Health Organization. So what ends up happening is that the information that's coming to the World Health Organization is coming in later than what you would like in terms of preparedness. Whereas if you have someone who's in that region where all of a sudden something comes up, or you have someone who's in that national institution and something is reported, then you have the ability to share that with everybody in a real-time manner before the World Health Organization is even able to be, to put together a statement or some kind of guidance. Remember, when you're dealing with the World Health Organization, the first thing that happens is information is developed by the researchers, the people who have the PhDs. And then what happens is it goes through a vetting process to be absolutely sure that they got it right. And only then will it come through in the public sort of realm and be shared by whichever representative happens to be in charge at that time. It's a very important process to go through, but it does take time. Whereas if you have that immediate sort of red alert preparedness, then people can start getting ready. And if it happens to be nothing or a false alarm, well, that will happen, but it's better to be prepared for something that may or may not come than to be taken off guard by it. And I'll give you one example. Here in Canada, a number of years ago, we ended up hearing about a minister who was going to be talking about something that had happened in Canada. And we were all kind of wondering what was going on. Even I was sitting down on the couch looking at the TV going, what happened? Well, it turns out H5N1 had come to Canada, avian flu.
Right.
Now, we didn't know any of the specifics. We just heard H5N1 had come to Canada. My goodness, that was frightening. Now, granted, when we finally found out the details, it was one case. Unfortunately, the person had died. There had been no secondary spread, and the institutions had been fully prepared. And so that was great. But we don't want to be in that situation. We want to be in a place where we're prepared so that if we all of a sudden hear that H5N1 has come to our shores, we're ready for it. And I think that's where COVID-19 has finally given us the ability to harness that and to take advantage of that and to put the proper resources into it so that we can develop that down the road.
How so? I mean, are you talking about a systems that each country would have, or a worldwide system, or a network of researchers, or let me back up. How would it work? How would that have worked with COVID-19? What you're talking about, the preparedness.
So when COVID-19, SARS-CoV-2 was first detected, and this was at the end of December, there was some information that was being shared, and it came through the ProMed mail. But there was no real knowledge about what was going on. All we knew was that there was this new novel virus that seems to be causing a pneumonia that possibly could be leading to a higher mortality rate. That was it. Now, even with that amount of information, you kind of think, okay, well, maybe we should have some kind of preparedness. But then, as we found out that there was human-to-human transmission and that this did have a higher case fatality rate, you started to realize, okay, well, if this thing starts to spread and it comes to our shores, then it's going to be a big problem. And we're not going to close borders. I mean, that's the first thing you have to realize, is that you can't rely on the politicians to do the right thing.
Right.
What you can do is start saying, okay, well, if this thing is kind of like SARS, and we knew that as of January 10th, if this thing really is causing the type of pneumonia and secondary sequelae that we were seeing with SARS, and people should be very read up about SARS. I mean, we're hearing about things regarding this virus in its terms of its sequelae that we already knew happened with SARS.
Right.
But for them, it seems to be completely brand new. And we can talk about sort of the short-term memory in a little bit, but I want to point out that if you were to keep that in there, that would be part of your preparedness plan. So all of a sudden, now you hear that in this particular area of China, with 11 million people, in an international airport, you have a virus that could possibly be as lethal as SARS and showing difference, or showing the same types of symptoms as SARS, has the same genetic sequence for the most part as SARS. Why not put in a SARS plan? And then that way, if it shows up, you're already ready for it. And so this is why you need that multidisciplinary nature and why you need all these different stakeholders. Because when you finally get to that point where everybody's talking to everybody else and sharing information, you're going to have a much better preparedness at any given time. And we would not be taken to the same extent of lockdowns and other things as we have with this particular virus, because we would simply know when it was coming. We'd be able to trace it back very, very quickly, and also invoke those proper isolation procedures that are necessary in order to avoid having to go through full lockdowns and quarantines.
Who would be doing it though? I'm trying to get a grasp of how it actually would work on the ground. Would the CDC be reaching out and getting this information, and then contacting the hospitals and the state health departments, I guess, and tell them that this is coming, and stock up on the PPE, or I'm trying to get an idea of how your system would actually work.
Yeah, so what you want to do is you want to make sure that you have a representative in every healthcare institution. But that representative essentially is just someone who knows that there's a phone number that they can call or an email that they can write. So if they hear about something, then they would send it off. Most likely, I would say, would be a nurse manager or one of the infection preventionists. And then they would be able to contact one particular authority that is essentially part of the region. And this could be a governmental role. This could probably be a healthcare role. Maybe one of the infection preventionists at one of the hospitals is responsible for making the call to a larger authority. So basically what happens is that it works in the form of a pyramid. So you have all the institutions like this here, which have somebody, and once someone sees something, it goes up one step. and then up one step and up one step until finally it reaches the ultimate pinnacle, which probably would be the World Health Organization. But we know that there are other infection prevention and control societies out there, such as APIC. We have IPAC here in Canada, and they could also be playing a role. And by the time you get there, it would be relatively quickly, hopefully within a few hours to 24 hours. And then that information would then essentially go from the pinnacle and then back down to all the different institutions so that they are aware. And in most cases, they'd probably be like, okay, that's very good information. It has nothing to do with us, and you move on. There's nothing wrong with that. But what is wrong is all of a sudden you have heard about something, you're not quite sure what's happening, and then all of a sudden in your ICU, you've got a number of patients who are showing classical symptoms of pneumonia. And then on top of that, all of a sudden they're showing DVT and other types of unexpected coagulation. And all of a sudden you're like, I don't know what I'm supposed to do here. And then, you've put them on ventilators, and then you realize that, oh my goodness, it could be possibly aerosolized, and then may have even gone into the ventilation ducts. We went through that with SARS. These are things that happened with SARS.
Right.
We don't have to go through that again.
So what you're saying is, an infection preventionist will say an infection preventionist that works at Johns Hopkins. Back in January, she hears about this mysterious, like everybody else, this mysterious occurrence in Wuhan, China. So then she talks to a regional health authority or somebody. She makes contact with. Sounds like you're talking about a bridge between hospitals and government health departments in a way, right?
Yeah, and we have seen something similar. It's just I haven't seen it formally put into place as a preparedness, like I have seen frameworks in the past. And I think the fact is we were going there, especially here in Canada with SARS. It's just it never took the hold that it was supposed to take. And so while we do have a very good version of that here in Canada, it's still not perfect. And unfortunately, as a result, we still saw this virus spreading like wildfire in certain parts of our country.
Right. Right.
I think that that's preventable. I think that that is preventable simply as a result of the fact that knowledge can travel incredibly fast. I mean, if everybody happened to be on a Slack or something along those lines, the information could travel in a matter of microseconds to absolutely everybody. So we should take advantage of where we are in terms of our ability to share knowledge quickly, rapidly, and rely on the people who are properly trained to be able to see the information, vet the information, and know whether or not this is something that we should be really focused on, or whether it's something that we need to sort of, keep in mind, but not necessarily act upon. And then it will essentially look patchwork when you start seeing maybe one hospital taking some measures, and another one that's not. But perhaps that hospital that's taking measures has an international hub that links to the source of the virus, whereas the one that's not is a complete remote community where there's almost no travel.
So for infection preventionists, then you're saying that one of the ways their job would change is that they'd be on a lookout for this sort of thing. They wouldn't just be involved in their hospital. They're heavily involved in their hospital. They make the rounds. They're in contact with hospital administrators and environmental service teams, but they also would be kind of looking outward at what's going on in the world and ready to alert or get information from government agencies or give information to government agencies?
Yeah, essentially it would be virtual point prevalence testing. So the minute that something comes up, it's immediately put into the logs, whether it be an information flow or something that is immediately shared with everybody else. And we all know what MRSA point prevalence testing does, right? Mm-hmm. It gives us an idea as to what the risk of a particular MRSA strain happens to be within our institution. Well, it's the same idea. It's just that you're taking it on a global scale, and it's essentially any kind of virus that we know could possibly lead to outbreaks, epidemics, and as we saw today, pandemic.
Any other changes you see, Jason, coming up in how healthcare is conducted as a result of COVID-19? And again, specifically to infection preventionists, hospital administrators, environmental services teams. Anything else you see in the future?
Well, I think another thing that we've seen, especially with respect to this particular pandemic, is the fact that we have really taken infection prevention for granted in many ways. We know all the processes. We know PPE is necessary, right? But at the end of the day, is there enough of the resources available to us to be able to invoke proper prevention and control procedures? We've seen in many places that's not the case. So I think what is going to happen is that infection preventionists are going to have a stronger voice in the larger healthcare community. When healthcare leaders are meeting, I think that they're going to listen to infection preventionists much more than they have in the past. I think that they're going to look at how patient satisfaction, quality of care is not just simply a matter of them having a good stay and maybe having some meals that they actually enjoy, but also making sure that not only do they as patients not come down with some kind of infection, but that the institution itself is safe so that they can have visitors. I mean, think about it. How many stories have you heard? And we saw this with SARS. How many stories have you heard where we are essentially hearing about people who are in hospitals in critical care and they can't have visitors because of the restrictions that have been put into place?
Those are some heartbreaking stories. You're right.
It is. And the fact is it's totally preventable. We know it's preventable. But in order for us to be able to make sure that this isn't the case, we have to have that preparedness in place. And the only people who really can give any insight into that are infection preventionists. I think for the next few years, their role is going to be more about being ambassadors of health when we have an invisible and unknown enemy than it will be of the day-to-day. And I hope that everybody who is watching, who's listening, takes up that challenge, if you will, and shows that they are now a representative of a better way of doing healthcare, of a safer way of doing healthcare. And if that happens, we may never have to worry about what we saw with COVID-19. And instead, we'll be well prepared for anything that may happen to come into our emergency room doors.
Jason Tetro, thank you so much for joining us here today at Infection Control Today. And be safe.
It was such a pleasure. Stay safe. And again, everyone who's watching, you're doing a fantastic job. And I applaud you all.